Hello.
Hi, everybody's hiding. Whoa. It says we're already streaming. Is that true?
Uh, I don't know yet. We shouldn't be. I hope not.
What I see says live on custom live streaming service recording.
Good morning and welcome.
Good morning, Doctor. How are you?
Doing well.
Good morning.
So you're in Tennessee? No, you're in Atlanta.
I'm in Atlanta, so yes, good afternoon. But I'm I know it's morning for you guys.
It's actually about to be afternoon in a few minutes.
Dr. Maxey, I have a question. Do we show our video throughout the whole thing, or when somebody else is speaking, should we hide our video?
No, you can keep your video on, but I think you want to mute your sound.
Okay, sounds good. Thank you. May I just test sharing my screen right now?
Sure. I hope either Simon or Martin are on. They sort of handle that.
Well, no, I know how to do it. I just so that you guys are comfortable. I mean, I know how to do it, so I'm fine.
Okay.
Or I could test it. I think we're already streaming, so I just don't know.
Okay.
Hello.
Hi.
Good afternoon.
Good afternoon, Dr. Berto.
How are we doing? Dr. Maxey.
Okay. Meet
Good
Dr.
afternoon.
your colleague.
Good afternoon.
Good afternoon. So I'm Kamara Jones.
I'm Helen Davis.
Vladimir Alberto.
Thank
Hello,
you.
Dr. Davis. We'll be getting started at 12 o'clock, so if we can just relax a few minutes, people will be joining and we'll start streaming.
Okay.
Thank you.
Hi.
Hi.
I'm new member of Black House Trust.
What's your
My
name?
name is Ty.
Hi, Ty. I'm Kamara, Miss Kamara.
Mama. Yeah.
Okay.
Hi, Victoria.
Hello, Vicky. Hello, Miss Michelle.
Hello, hello.
I was looking for
Is
the
that-
home trees.
Hi, how are you, Dr. Jones?
Hi, I'm good. Nice to
Good.
see you.
Is Martin on
Yep,
the call?
I'm here.
So Martin, should I put is it okay to put the screen, the background screen on or no?
Yeah, that's right.
Okay.
You put that on, we all take a vacation with you.
It helps my mood.
Wow. Beautiful background.
You see
Yes.
the difference?
Wow.
And the fact that it moves, like some of them are just a picture, but this is nice.
Yeah, I love that.
Right now, this is a dream.
Exactly. Fake it until you make it. Huh?
Mhm.
So Michelle, I'm gonna step away to get some coffee. I'll be right back.
Okay. It's 11:55, so we'll officially start in about 5 minutes.
Although I see, at least on mine, it says it's recording and already live on custom live streaming service. Are people seeing us or no? Are we still in the?
I'm not sure, so we better behave accordingly. I'm not sure.
I would venture to believe that we are probably already live. This is our living room portion of the call
Right.
program. Matter of fact, I'm just going to step away for just a moment. I'll be back.
Hi, David.
Hey, Kamara, how are you?
Good. How are you?
Okay, great to see you.
Yep. Likewise.
Likewise, likewise.
Is that Dr. Carlisle?
Dr. Maxey, I don't think he heard you.
Is that Dr. Carlisle?
Yes, yes. Dr. Maxey, how are you?
How are you? Thank you for honoring us.
Oh, it's a pleasure to be here. I didn't want to miss it. I'm turning up my volume a little bit. Your voice is actually a little bit low.
Right. Aside from Desidare, possibly do that. Other treatments mostly supported, right? Maybe use steroids.
So Dr. Maxey, can you put your camera down a little bit so we can see? Oh, there you go. That's okay. You're fine. That's better. Okay.
That's great. So it's noon, folks. There are 13 participants on the line. However, we have many more we can't count on the Zoom conference. So let's go ahead and get started. Good afternoon and welcome everyone to the weekly Black Health Trust program. My name is Michelle. I'm coming to you from Los Angeles and I'm your host for today. Today's discussion is moderated by the distinguished Dr. Randall Maxey, who happens to be Chief Medical Officer of Advanced Community Medical Care Corporation here in LA. The mission of the Black Health Trust is to provide credible insights from our community health experts to best serve our communities of color with a coalition of leading and long-standing Black professionals across a diverse spectrum of disciplines in medicine to offer unvarnished opinions and insights into our physical and mental health during these challenging times. I want to share just a few housekeeping items for the meeting. Please be advised that this video conference is live and being recorded on different public platforms such as Facebook Live, and that your participation on this call is voluntary. If you do choose to participate and prefer not to have your image and likeness displayed, you do have the option to block your picture and mute your phone by changing the video and audio settings on your device. Everyone's audio will be muted initially until the host or facilitator asks you to contribute in order to minimize distractions and background noise. So make sure your device is on mute until called upon to speak, and then once again, place your device back on mute when you're done speaking. Thank you so much for that. As for the chat room, this is where you'll enter any questions you have. Please limit your questions to 2 per topic being addressed, and please do not use the forum to advertise or promote your projects or products. It sort of convolutes the discussion in the chat room. Understand that there may not be sufficient time to get to all the questions during your call, but we will do our best. Please also note that the information communicated on this call is not deemed to be medical or legal advice, and you should always consult your own medical or legal professional for advice pertaining to your particular situation and needs. So that said, a big welcome to all of our distinguished physicians and special guests. We thank you from the bottom of our hearts for sharing your time, your information, and educated insights with us. We're so blessed to have you participate on this call and that you care so much about our community and support it in this way. So thank you once again. Welcome everyone to the Black Health Trust program. May the divine guide our words and our works. And I now invite Dr. Randall Maxey to begin moderating the program.
Thank you very much, Michelle. We appreciate you. We appreciate all of our guest speakers today and all of you for joining us. This call started a few months ago with just a few people trying to make sure that friends and family were safe. We now have over 7,000 people attending the calls, and we're very concerned that we keep this going. It is our reason to give this call to have credible health information. There's so much bad stuff on the internet. There's so much counterproductive information that we want to make sure we bring to you physicians of color throughout the United States to give you information that is credible. As Michelle said, we're on here as giving you information, but we're not trying to take the place of your physician. So make sure that anything you hear, you check with your own personal physician if you have one. I'd like to give honor today to the Honorable John Lewis, who had his funeral today, and many of us witnessed that. And without heroes such as John Lewis, we know that we would not be doing the things that we're doing today. And he very much said, if you see something, you need to do something. And the Black Health Trust is stepping up to do something. We have interesting and distinguished and skilled speakers for you today. We have Dr. Helen Davis, who is a board certified ophthalmologist, was trained at the Bass Lawn Academy in Florida. I hope I said that right. I probably didn't. We have Dr. Kamara Jones, who is at Morehouse, and we have Dr. Vladimir Bertos. I'd like to also welcome the president of Drew University and College of Medicine, Dr. David Carlisle, who is on the line. Comment later. I'd like to start off with just a little bit of observation from my standpoint. We know that this COVID disease is real. We know that it is affecting our families. We also know that many people just don't believe that fat meat is greasy. They don't believe that this is not a hoax. I want to assure you of that. It is not a hoax. And accordingly, we must wear masks. We must do hand washing. We must fortify our immune systems. We recommend using micronutrients. I'm not pregnant, but I do take prenatal vitamins, which has many of the micronutrients. I recommend that people take vitamin D3. Some have taken as much as 50,000 units per week. Vitamin C, 2,000 milligrams per day. We ask you to eat a plant-based diet. We ask you to wash your hands incessantly. I tell people, wash them every time you think about it. Plain soap and water is deadly to this virus. And then you can also use a hand sanitizer. I believe that this pandemic and the lockdown in various communities are going to require us to have food at home that's not perishable. And you should have at least 2 to 3 months supply. I'm not suggesting you hoard things, but you must be prepared. Those of you who are blessed with a backyard can have a garden, and that is very important. From my standpoint, I'm a kidney doctor. I recall a number of weeks ago, I was called to consult on a patient in Mississippi. She was 35 years old. They consulted me at 11 a.m. At 11 a.m., her systems were starting to fail. She had several strokes. She had heart failure. She developed kidney failure. Remdesivir was not available in that particular part of Mississippi. We were trying to arrange to get it from Jackson, which was a 2-hour drive to where she was. Unfortunately, even after initiating renal replacement therapy or dialysis, she expired by 5 p.m., 35 years old. But of course, she had risk factors. She was 35, but she weighed 450 pounds, which is a risk factor. We also know that many Black people have an upregulation of their ACE2 inhibitor sites. These sites happen to be located in the nasopharynx, which is a point of entry. We also know that they manifest themselves in the kidney, which is a point of entry once they get into the body. We know that another site of entry is in the mouth, the nose, and the eyes. So we suggest that all of these entry points be covered. I'm going to ask Dr. Helen Davis, who is an ophthalmologist working in Bakersfield, California, formerly Associate Professor of Medicine at University of Rochester, to be our first speaker. And we also have a surprise for you as we go on. Dr. Helen Davis, the floor is yours.
Thank you. Thank you for having me in, and also thank the Black Health Trust for all that you do to help save Black healthcare and to reach out to people who have poor access to care. I'd like to pose a question. Can you get COVID in the eye, and how serious is this issue? Dr. Maxey expounded on a lot of the things that we do know, and what we do know is that the main port of entry would be through the lungs in terms of causing the most serious consequence. Okay, so however, the eyes possess itself as a portal. Okay, I'd like to present a little slide presentation, and if I get a little long-winded, let me know. Okay, so officially about 2 years ago, poor handling of bats in China alerted the U.S. that there were safety lapses and this could possibly be a corona outbreak. Well, interesting enough, a Chinese ophthalmologist whistleblower noted an eye connection with the outbreak in the Wuhan wet market. Now, as you can see, there's a lot of wet this a man versus man to man? Well, many people, and then maybe it didn't necessarily originate from any animals or the bats, because many of the animals that were tested there all came up negative. As Dr. Maxey mentioned, there's a variety of symptoms with COVID, and some that are less common, and being in the eye is relatively less common. It was interesting enough that recently over 6 mutated strains of COVID-19 have come along, and which has showed us that there's so many possibilities of that this virus can keep mutating because there's over 100 strains of coronavirus. We know it's easily transmitted. We know that it can linger. And some people have even reported that it's reoccurred twice. But most interestingly is that there are many asymptomatic carriers. And the question is this virus just spreading so much because of the asymptomatic carriers are the main culprits? Well, as healthcare workers, we are at risk. But interesting enough, working in the eye, ear, nose, and throat and dental office pose you at even more risk. All essential workers are at risk, and especially if you don't mask up, glove up, or wear any eye shield protection. Interesting enough that the COVID virus not only can cause a conjunctivitis, but it's believed that you can contract COVID systemically from the virus through the eyes. The ophthalmologist whistleblower stated that he contracted the disease from an asymptomatic glaucoma patient. He was poo-pooed and booed down and even put in the jail because nobody believed him that this was actually the source, and as if he was spreading bad news for China. Well, my question is, how many asymptomatic people are carrying COVID, and how are they spreading it? And are healthcare workers actually helping to spread the disease indirectly? Of interest, the eye is like a magnet for COVID virus because of the many ACE2 receptors on the eye. And even viral RNA has been found in tear samples and conjunctival tissues, so the eye has an affinity for the virus. Not only is in the tears, it's in the cornea and the conjunctiva, but it's in the aqueous humor, it's in the ciliary body, it's in the retina, and it's also in the periocular skin. So all these are potential vectors of spread to the eye. So the eye is a prime target for COVID and potentially a gateway or portal into cells inside the body. And respiratory infection could be transmitted via the eye simply by tears or the mucus secretions from the tear gland in the eyelids. This ends up through the tear pathway into the nose. The tears pass from the lacrimal gland, across the cornea, into the tear ducts, into the tear sac, and down into the inferior meatus of the nose. So respiratory infection could be transmitted by the eye and the lacrimal nasal pathway into the nose, which ultimately can end up in the lungs. So the eye could be a discrete portal of coronavirus infection by way of the tear flow pathway into the nose, to the nasopharynx, to the lungs. As we can see here, all these tissues are in close proximity, and just by either by direct contact or just by the natural lubrication, the attraction of the COVID virus to the eye and other surrounding tissue. Well, it's easy to see how we easily can inoculate the eye. In addition, particles from a sneeze can travel up to 26 feet and can get into the eye, land on the eye. Coughs, sneezes, blowing your nose, all these could potentially end up as droplet sources to end up on the eye, which ultimately could end up in the nose and into the nasopharynx and into the lungs. Germs can actually travel quite a few distance, and even though we're 6 feet of social distancing, some studies have shown that germs can go up to 10 feet, and so 6 feet might not be adequate. Airborne contagious virus could stay in the air for hours, land on surfaces, land on materials, on the skin, and this all can indirectly enter into the eye. Conjunctival infection can be due to droplet inoculation of ocular tissue and the mucous membranes of infected individuals. So not only can the droplets cause a conjunctivitis, but also the droplets, we believe, can be transmitted through the eyes to cause a severe acute respiratory syndrome. Well, COVID conjunctivitis is actually a new disease entity. It is a manifestation of COVID-19, and it basically presents like a regular red eye, watery eyes, foreign body sensation, but it may be the only sign of COVID-19, and sometimes it may just develop later in the course of hospitalization, or it may not ever get you to the hospital, or it may only be, but it's more commonly seen in more severely ill patients. Basically, it's inflammation of the conjunctiva with injected, inflamed, congested vessels, lots of pain, lots of secretion. A study in China showed that 1/3 of the 38 COVID positive patients actually had ocular symptoms. But the ocular symptoms are often underplayed because sometimes that might be the only symptom. Patients may be asymptomatic, they might not be febrile, and they may just think it's just a pink eye or a red eye. But, and so they're often overlooked as a possible source of the acute respiratory syndrome or prodrome to the acute respiratory syndrome. There are many different causes of red eyes, and so many times it's just poo-pooed. Even in healthcare workers who have a red eye, just think their eyes are tired, a little itchy, a little tearing a lot, or people just think they have a red eyes and they just sort of hide it and never get tested. But the single most risk factor is direct contact with a person having COVID. And the whistleblower, as we mentioned, who actually uncovered the connection between the eye and the systemic disease, actually contracted the virus from an asymptomatic glaucoma patient. He eventually succumbed to the disease as well. Now, if you had a sick patient in the hospital with multiple other comorbidities and encephalitis and other things, well, you probably still wouldn't pay attention to the eyes, but actually his symptoms could have started with the COVID conjunctivitis. Ocular symptoms are more common, as we mentioned, in more severely diseased persons and also with disease and severely deranged blood counts. And of note, to make my point, the virologist, NBC correspondent, Dr. Joseph Fair, was actually hospitalized with COVID-19, and he thinks he got it through his eyes. He traveled on a crowded plane with a mask and gloves, mask and gloves. He thought he was doing proper social distancing, but he noted that the flight attendants were not wearing masks. And so he thinks that, well, we're paying attention to everything else, but what about our eyes? And he thinks he actually contracted it through his eyes with the flight attendants in airborne and other people not wearing any protection on their eyes. This is the gentleman here who is still trying to recover from COVID. And his main point is wear protective eyewear. And this gentleman survived Ebola, but he has not totally survived COVID-19 yet. As mentioned, 1/3 of patients in the recent study from JAMA and Lancet showed that they had ocular symptoms, and these were severely diseased persons. There might be higher abnormal blood work, which the medical people would test to confirm COVID-19. But the question is, well, most influenza viruses that affect the respiratory systems do affect the eyes, so why not COVID? It should have been something thought about early and also precautions taken early. The eye is not a preferred organ or preferred gateway. However, pathogens exposed to the eye surface through the tear film can end up in the nasal pharyngeal mucosa and ultimately enter into the respiratory tract and cause SARS infection. So there is an eyes, ear, nose, and throat connection. So there are many studies that show positive RNA in the tear film, and that the infection could start in the eyes, and perhaps the virus could enter into the body. The American Academy of Neophthalmology was so concerned that they actually put this bulletin out to its membership. The infection could start in the eye. The virus could enter the body through the eyes. Another bulletin they put out is that pink eyes could be an early symptom of coronavirus, and ophthalmologists may be the first providers to evaluate patients possibly infected with COVID-19. Well, how could COVID-19 get in the eyes? Well, it's easy. We saw the pictures: hand to eye, hand to eye, hand to eye to eye, hand to nose to eye, droplets, airborne, aerosolization, as well as fomites to eyes. Well, what is the implication? The implication for eye care professionals, we are at higher risk of acquiring COVID-19 during our professional duties since we have very close physical contact with the patients. Our exams are usually close face-to-face or close eye-to-eye. We routinely work with high-risk patients with AIDS, immunocompromised, autoimmune disease, patients on chemotherapy, on immunomodulatory therapy, patients with infectious disease, diabetics, obese, elderly, COPD, sleep apnea, frail individuals. That's the nature of our routine activities. And furthermore, eye surgery is associated with secretions and aerosols, especially cataract surgery, because of the fecal emulsification debris from ultrasound that's being spread in the atmosphere. So this enhances our tendency to be in contact with SARS-CoV-2 in the tear film and conjunctival secretions. This is some examples of our close eye-to-eye doctor-patient contact. We're at a slit lamp, touching eyeballs, touching eyelids, touching tears. We're touching instruments that could be become fomites. And we're like face to face in the face and the eyes, next to the nose and next to the mouth. So the American Academy put out another bulletin. Any person coming to the eye clinic with a red eye should be considered COVID-19 positive until proven otherwise. We found it in the tear film. We found it in the RNA and lacrimal secretions and conjunctival secretions. And we know that the disease can be transmitted by droplet and aerosol infection, and because the surface of the eye is pretty full of ACE2 receptors. So the tear film may be the important entry of coronavirus into the nasopharyngeal pathway. The conjunctival infection due to direct inoculation. As we can see here, the pattern from the lacrimal gland, the tear film going across the face of the globe, the cornea, into the puncti, into the nasal tear sac, lacrimal sac, and down into the tear duct and into the inferior meatus of the nose. This is the gateway passage. In addition, you can see all the secretions that may be increased related to eye inflammation and infection and draining directly into the respiratory system. When there's typical, when there's no disease and everything's working normally, most of the tears evaporate by the time it hit that area. So from tears to nasopharynx to lungs, COVID could be implicated as a gateway entry from the eyes. Now, we know comorbidities are important, but the greatest risk factor for COVID conjunctivitis is direct contact with a person having COVID. Red eyes alone should not be dismissed or trivialized. A patient with a red eye or pink eye should have some history taken. And have they traveled, they're coughing, they have fever, and not just think it's a plain old conjunctivitis, allergy, or just local irritation. Some eye signs of COVID-19 are, it may start off as a unilateral redness, but a follicular reaction is usually typical of a virus. The cornea may be inflamed, and in severe cases, the retina might even be involved. But importantly, tender preauricular lymphadenopathy may be an early sign of symptoms of COVID-19. You can see it in the beginning of the course, or you can see later in the course, or you can even see it in discharged patients. Here's where we see where one of the first clues might be swollen lymph glands around in front of the ear and with a red eye. And then that's when the history taken is very, very important. Patients may be asymptomatic early and untested. That's why it's missed. there's a low index of suspicion that something as simple as a red eye or pink eye could be the culprit as a gateway to COVID-19 infection of the lungs. In addition, there's usually insufficient testing. We hardly even test for regular viral infections, adenovirus or bacterial infections. We just kind of empirically treat. And so there really is inadequate testing to confirm it and so that's why the patients may go on to other symptoms of COVID-19. And then the little testing we have show a lot of false negatives. So as a result, this has brought about drastic changes in the eye care practice. And so and because of the scarcity of medical resources, the scarcity of available testing, and the highly infectious nature of this disease, our focus is now on treating emerging conditions during this pandemic. In other words, if you don't have an emergency, you really should stay out of the eye clinic. You don't really need to worry about glasses and contact lenses. You need to worry about red eyes, painful eyes, loss of vision. So we've sort of done like most primary care people doing. We're doing pre-appointment screening, wearing masks at all times during the whole course of examination, and of course, recommending the usual hand washing, disinfection of instruments and services. But additionally, we're avoiding some other common ways of examining patients that we typically examine. In other words, instead of doing an air puff tonometer to check your eye pressure, we might have to do an individual pressure check or a touch test or something and sterilize behind each test. We'll do a minimum examination protocol, minimum touching, feeling in the face, around the mouth, around the nose. And also now we're recommending proper slit lamp and phoropter breath shields. And I'll show you a picture later what a breath shield looks like. And also, more importantly, in addition to masks and gloves, we're suggesting that people who work that close to patients should wear protective eyewear, a face shield or goggles, in addition to their glasses and the mask. Furthermore, something new for ophthalmology, the implementation of telemedicine has certainly boomed because normally we're so visual, we haven't done much. And now we're doing a lot of Skyping. And of course, elective surgery has been put on hold. So this is an example of a good eye shield if you're going to be around a lot of secretions and also things that could splash around the eyes, because as we know, droplets could go into the eyes. So the people working around intensive care units and the hospitals have been pretty good about this, but I would say that eye clinics and other doctors' offices have been a little negligent about eye shields. Here's an example of a brush shield on the phoropter so that there's a little interface between the patient and the doctor to cut down some aerosols. I'm going to call this a new terminology. I'm calling it medical distancing, eye exam medical distancing. Brush shields, goggle or face shields, mask, gloves, disinfectants spraying in the room as well as on the surfaces, more virtual eye exams, less hands-on, less face-to-face contact, less touch, and less direct ophthalmoscopy. There's many differential diagnoses of a red eye, and there could be a myriad things in this causing a red eye, and that's why a pink eye, red eye has been trivialized, because the diagnosis could be 100 different things, but should have a high index of suspicion, especially if someone is febrile or has preauricular lymphadenopathy, or they've been in contact with a COVID positive patient. So the eye testing has been specific, but not so sensitive in the diagnosis of COVID conjunctivitis. However, if there's a high suspicion, you need at least 2 consecutive PCR tests before you can say a patient is safe. Immunology of COVID testing might be helpful. And I just sort of summarize that if you're high in IgMs, you're probably active and have a recent infection. If you have positive IgGs, the infection is probably old or you're coming out of it. However, an IgG test alone does not mean the patient is no longer contagious. So you need IgM and IgG. COVID conjunctivitis is usually self-limiting. That's the good part about it. But it's still important to know that COVID might be transmitted through the eyes. IgA is becoming a novel therapeutic antibody because it's been shown to neutralize the virus in mucosal tissue. And so there's some investigational things going on looking for IgA as a possible antibody for COVID-19. It's still early in the course.
Dr. Davis,
Mhm.
when somebody has a red eye and possible sore throat or lymphadenopathy, what do you recommend that they do at that point?
Well, history taking and contact tracing it would be very important. And they should be followed fairly closely or monitored, and they should really try to do some self-quarantining just to make sure that they're not possibly going on to COVID-19 full-blown SARS situation. So the level of suspicion should be there, should raise the index of suspicion. It should not be overlooked because this virus is spreading so fast and we don't know all the sources. And it may be, we know they're asymptomatic people, but it may just be these little pink eyes are spreading because they're trivializing their symptoms and they're still going about the normal activity.
I'm also noticing more and more patients are coming into my office wearing face shields. I think that is really good. That should
I am very happy to hear that because they have gotten the message. They got the memo. Aerosols, things in the air, and then there are all kind of other conspiracy theories about droplets and being sprayed and being in an environment where people are intentional super spreaders. So I think that's a good thing. It's worth $4 to save your life. You know, it may look ridiculous to some people, but I would say drop the contact lenses, wear the glasses, wear the face shield, wear the mask, and wear the gloves, and practice social distancing until we know what's going on.
I thank you for your very astute presentation, and we're going to have questions for you as we go on. Michelle, are there any questions in the chat box for her right now?
Not at this moment. I'll let you know.
Okay, very good. Our next speaker is a young lady who is an associate professor of medicine, I believe, at Morehouse College of Medicine. I had a conversation the other day with one of my friends and great heroes, Dr. David Thatcher. He was telling me about the great work that Dr. Tamara Jones is doing. He sent me her bio. I read it, I said, this woman must be 95 years old. Things that she has done. She has been an professor at Harvard. She has graduated from Wellesley. She went to Stanford.
You're very low, Dr. Maxey.
She has been recognized academically.
You're still a little low. We want to hear all the accolades and accomplishments. We really do. So you got to have to back up and restate a lot of what you just said. We can't hear you.
Can you hear me now?
Yes, wonderful.
Okay, I'm trying to be modest. Dr. Tamara Jones is an MD. She has a master's in public health. She has a PhD, which is a doctor of philosophy. She is an epidemiologist. She is a family practitioner. She has attended Harvard Medical School, Stanford Medical School, Wellesley College, and probably, I think, Johns Hopkins too. And she is not 95 years old. She's a young, aggressive, very nice young lady. And today, I'm going to say happy anniversary to her. And she's so young, she's only been married 2 years. I know that. Dr. Tamara Jones, we appreciate you joining us. The floor is yours.
Thank you so much, Dr. Maxey, and thank you for that presentation, Dr. Davis. What it let me know is that as I was thinking about getting my cataract removed, now is not the time. I sort of knew that, but you just impressed me with that. So I would like to share my screen. I would like to start us on a conversation about racism. And so my work, as Dr. Maxey says, I'm a family physician, PhD epidemiologist, and my work is on naming, measuring, and addressing the impacts of racism on the health and well-being of the nation. And I've been doing that work for decades. And then all of a sudden, when we started recognizing in early April that this new infection to which none of us on this planet was immune in December of 2019, that all of a sudden we were seeing the Black and Indigenous and brown bodies just piling up so fast that we couldn't just normalize it or ignore it. And people started acknowledging that COVID-19 had actually grabbed the sheets, I say, off of structural racism in this country. And so since, first of all, that recognition of the disproportionate impact of COVID-19 on Black and Native American and other people of color, and then after that, insult to injury, the murder of George Floyd with equanimity on Memorial Day, and what we had just learned about killings, police killings from 2 months before of Breonna Taylor, and then we learned about the vigilante killing of Ahmaud Arbery, which had been 2 months before. All of a sudden, everybody right now, not everybody, I have to admit, not everybody, but a lot more people than had before in this country are naming racism. People are affirming now that Black lives matter. People are saying the word systemic racism, structural racism. That is good. But it is my intent that we do not fall back into what I describe as the sleepiness or the somnolence of racism denial, which is kind of where the US mostly is, like folks staunchly in denial that racism exists, that after this a little bit of awakening, that we don't fall back. So what I want to do right now is share with you a story and then just some tools so that you can be equipped to be part of the army that keeps naming racism on the agenda. But then we need to go beyond that. It's good to name racism, but we need to figure out how is racism operating here. We need to then use our insight about how racism is operating to organize and strategize to act to dismantle this system. That is what I'm going to share with you in about 10 minutes, 10 or so minutes. So the first part of it is a story that I want all of you to listen to first, but then remember and please share this story with somebody else today, somebody in your home who's not behind your shoulder looking at this, or somebody who's at work or on social media. I call this story Dual Reality, a Restaurant Saga. And the moral of the story, I'm going to tell you from the beginning, is that racism exists. And this is especially a good one for you to share with people who might think that racism doesn't exist. Maybe it was something in the past, but you know, we're past that, we're beyond that. So let me tell you what happened to me. When I was a first-year medical student, I was very studious. So one Saturday, I wake up early and I immediately hit the books. I'm studying, diligently. And so some friends come over, it's Saturday. And so what do? We all start studying long and hard. And it gets late, we're still studying, and we get hungry, we're still studying, and I have no food in the apartment, which was typical for me. So my friends understood, but they were like, never mind, Kamara. Let's go into town and find something to eat. So that's what we did. We go into town, we find a restaurant, we walk in, we sit down. The menus are presented, we order our food, the food is served. Here we are eating. Not a very enlightening story about racism, not yet. But as I sat there with my friends eating, I looked across the room and I noticed a sign, and that sign was a startling revelation to me about racism. So now I've intrigued you and you're trying to remember, where did Dr. Maxey say she went to medical school? You know what? What did the sign say, Dr. Jones? What did the sign say? What did the sign say? The sign said open. So now I know I've lost many of you. So let me recap. Here we are, sitting in a restaurant eating. I look across the room. I see a sign that says open. If I hadn't thought anything more about it, I would have assumed that other hungry people could walk in, sit down, order their food, and eat. But because I knew something about the two-sided nature of those signs, I recognized that now indeed the restaurant was closed because of the hour, but firmly closed, and that other people, other hungry people, just a few feet away from me, but on the other side of the sign, would not be able to come in, sit down, order their food, and eat. And that's when I understood that racism structures open, closed signs in our society. That racism structures, if you will, a dual reality. And for those who are sitting inside the restaurant at the table of opportunity eating, and they look up and they see a sign that says open, they don't even recognize that there's a two-sided sign going on because it is difficult for any of us to recognize a system of inequity that privileges us. So, for example, it's difficult for men to recognize male privilege and sexism. It's difficult for white Americans to recognize white privilege and racism. It's difficult for all Americans to recognize our American privilege, or at least what we used to have like that, right, in the global context. But those on the outside are very well aware that there's a two-sided sign going on because it proclaims closed to them, but they can look through the window and see people inside eating. So back inside the restaurant, to those who ask, is there really a two-sided sign? Does racism really exist? I say, I know it's hard for you to know when you only see open. In fact, that's part of your privilege, not to have to know. But once you do know, you can choose to act. So it's not a scary thing to name racism. It's actually an empowering thing to name racism. Doesn't even compel you to act, but it does equip you to act so that if you care about those on the other side of the sign, that is an if, but if you do and you find yourself, maybe you were born inside the restaurant, what you can do is talk to the restaurant owner who is, after all, inside with you. And you can say, restaurant owner, there are hungry people outside. Why don't you open the door? Let them come in. You will make more money, and oh, the conversations we could have. Or maybe what you'll do is pass food through the window or try to tear down that sign or break through the door. But at least what you won't be doing is sitting back saying, wonder why those people don't just come on in and sit down and eat, because you'll understand something about the two-sided nature of that sign. So this story is to help all of us, and to be especially for those of us on this session today, to have a tool to talk about others who may have been born inside the restaurant, always look up and see open and have no idea. They would be in staunch denial that racism exists. This is a tool for us to say, yes, racism exists. It's creating two-sided or multi-sided signs. It's creating a dual or multifaceted reality. I actually started a 3-hour conversation once, just asking the question in Flint, Michigan, community group. I asked, how could people who are born inside the restaurant know something about the two-sided nature of that sign? We had a 3-hour conversation because there are many, many ways to know. What I just want to say quickly is that in our nation right now, it's as if maybe the air conditioning inside the restaurant went on high or something, or somebody told me, no, a brick came through one of those windows, but it made the sign flip. And a few people inside that restaurant saw that it was a two-sided sign and are now naming racism, as I said. But we have to encourage all of those companies that are finally, Black Lives Matter and finally talking about systemic and structural racism. We need to ask those people to go beyond just talking, because racism denial in this country is so seductive that if you say something 6 months from now, you'll forget why you said that thing. But if you start acting, you will not forget why you are acting. So I am just going to very briefly run through the rest of what I wanted to share with you. First, I owe you a definition of racism. I've talked about it now, and I've talked about how it structures these dual realities. But when I say the word racism, I'm clear that I'm talking about a system. So not an individual character flaw, not a personal moral failing, not even a psychiatric illness, as some people have suggested, but a system of power that does what? A system of power that does two things. It structures opportunity and it assigns value. And on what basis is the opportunity structured? And on what basis is the value assigned? It's based on so-called race, based on the social interpretation of how one looks in this race-conscious society. And this system of structuring an opportunity and assigning value based on race has multiple impacts. When we do talk about racism at all in this country, we understand that it unfairly disadvantages some individuals and communities. But it shouldn't take us long to recognize that every unfair disadvantage has its reciprocal unfair advantage. So racism also unfairly advantages other individuals and communities. That's the whole issue of unearned white privilege that we hardly ever talk about in this country because it makes some people, especially some white people, uncomfortable. When I'm talking to an audience and I think that maybe it's hard, in Zoom land, but, I'm like, oh, maybe somebody just felt a little uncomfortable when I just said unearned white privilege. I used to say, if you feel uncomfortable, shake it off. I'm going to tell you more stories. Stay with me. I don't say that anymore. Now what I say is, if you feel uncomfortable, you need to lean in, because I have come to recognize that for each of us, the edge of our comfort is actually our growing edge. But there's a third impact of racism that many of us miss, and that is that racism is sapping the strength of the whole society through the waste of human resources. It's not just that Black lives matter. Black lives are precious. Black lives are genius. Black lives are leadership. Black lives are creativity. Black lives are generosity and love, as are Black and Indigenous and Latinx and Asian and Native Hawaiian and other Pacific Islander lives. All of these lives that are constrained slowly when we don't invest vigorously in the full, excellent public education of all of our children. They are constrained more quickly now that we're already complacent, not only with the warehousing of disproportionately of Black and brown men in our prison system, we have already normalized the disproportionate impact of COVID-19 on communities of color. You don't even hear about that anymore, right? Or Black lives when they are cut short instantly by police killing unarmed Black and brown men and women, or vigilantes following and hunting down people as they jog. That loss of Black and Indigenous and other people of color life is not just a loss of the genius of the individual that impacts the family and the community. This is a loss that is sapping the strength of our whole society through the waste of human resources. I think we need to lift that impact of racism up higher in our media stories, in our data collection, and in our conversations around dinner tables, so that more people have a sense of urgency to dismantle this system and put in its place a system in which all people know and develop to their full potentials. Now, I am going to very quickly say, there's another story that I'm not going to tell you today. It describes 3 levels of racism and says that if we want to set things right in this country, we need to at least address the structural or institutionalized racism. And so you can either read the 4-page paper, or you can get go and listen to it as an interview of me where I tell the Gardener's Tale, or you could even Google Kamara Jones TED Talk and listen to 4 of my allegories, including a quick version of the Gardener's Tale. So very, very quickly now, how is racism operating here? Because 4 years ago, when I was president of the American Public Health Association, I launched our association on a national campaign against racism with 3 tasks. To name racism, I just gave you some tools to do that. The second task is to ask this question: how is racism operating here? The third task is to organize and strategize to act. So how is racism operating here is a legitimate question, because racism is not a fog, it's not a cloud, it's not a soup that we're going through. It is a system with identifiable and addressable mechanisms which are in our structures, policies, practices, norms, and values, which are different elements of decision-making, where structures are the who, what, when, and where of decision-making, especially who's at the decision-making table and who's not, and what's on the agenda and what's not. And if structures are the who, what, when, and where of decision-making, policies are the written how of decision-making, practices and norms are the unwritten how of decision-making, and values are the why. So how does this relate to COVID-19? Well, first, let's understand that the excess deaths of Black and Indigenous and other people of color from COVID-19 has 2 parts. We're more likely to get infected because we're more exposed and less protected. And once infected, we're more likely to die because we're more burdened by chronic diseases with less access to health care. So how is racism operating here in that? And very quickly, we're more likely to be exposed because of racial segregation of housing. First of all, there's disinvestment in our communities, and we're more crowded in our actual homes and in our actual communities, right? But then the same racial segregation of housing causes segregation of educational opportunities, which results in job segregation. So that's why we are on the front lines more often. Then the whole prison, school to prison pipeline and over policing of communities of color. And the foster care system results in disproportionate incarceration, where we're more likely to be exposed. We're more likely to be unhoused. All of these have structural factors. I'm not going to stay on this long. I have to just, policies include the limited availability of personal protective equipment for essential workers, but the low wage essential workers like the postal workers and the bus drivers and the people who are cleaning the hospitals, right? And also limited paid sick leave, limited family and medical leave, lack of hazard pay, all of these policies. So that results in we're more exposed and less protected. Practices like the location of testing centers, which still are not located in the areas that are being the hardest hit, right? And testing strategies where we're still not having a public health approach to testing. We're still not doing the kind of testing where we can identify asymptomatic as well as symptomatic people. And that is because, honestly, because the President of the United States has not invoked the Defense Production Act to create more tests. Why do we have a shortage of tests in this country? Norms are, especially the norms that result in racism denial, that start to blame Black people. Oh, well, they didn't take it seriously, or they don't know this, that, and the other, as opposed to understanding the structural factors that are at the root of our disproportionate impact. And those racism denial is it's supported by the norms of a narrow focus on the individual that makes systems and structures invisible or irrelevant. The fact that we're ahistorical and we act as if the current distribution of advantage and disadvantage were just a happenstance, as if the present were disconnected from the past. And our endorsement of the myth of meritocracy, that if you work hard, you'll make it. I give you that most people who have made it have worked hard. Not everybody who's made it has worked hard. We have prominent examples of that right now. But most people who've made it have worked hard, but there are many, many other people working just as hard or harder who will never make it because of an uneven playing field that has been structured and being perpetuated by racism, sexism. All of these systems of structured inequity. And our values, these values piece, this is very important. As hospital systems and state departments of health start having these crisis standards of care, you need to remember this terms, crisis standards of care, where the doctor-patient relationship is so stressed that now you can't do what you normally would do, which is have the patient's best interest at heart, because now you only have one ventilator and 10 people who need it. All the values in our society are being put in writing in these crisis standards of care, and especially when they're going to start using the existence of chronic diseases, the diseases that we have because we have been living in disinvested communities with poor opportunities, no green space, no food, poisoned air, poisoned water, and now they're going to say that that makes you less eligible to have a ventilator. So what can we do today? We need to look for evidence of two-sided science. It's important for us to continue documenting the differential impact of COVID-19 on communities of color. We need to, each of us, burst through our bubbles of experience to understand and know our common humanity on the other side of town, on the other side of the tracks, on the other side of that two-sided sign. Because many of us do not know that there are people just across town who are just as kind, funny, generous, hardworking, and smart as we are, who are living in very different circumstances. We need to be interested in the stories of others, believe the stories of others, and join in the stories of others. And I am especially heartened right now that that's what, when you look at the people who are still protesting and still asserting that Black Lives Matter, that looks like a more, like more people understand that. And so that's good. That's good. We need to develop a sensitivity to the absence of who's not at the table. Whenever you find yourself at a decision-making table, you should take a look around and say, who is not here, who has an interest in this proceeding? And then your job is not just to represent their interest. Your job is to create space to find them a way to the table. So who's not at the table, what's not on the agenda, what policies are not in place that would, if put in place, would be amazing. We need to reveal inaction in the face of need, because that is the way that structural racism most often shows up these days. Lack of action in the face of need. But all of the power is not on the point of view of those inside the restaurant, those on the outside. We need to know our power. We need to recognize that action is power, and especially that collective action is power. So I so appreciate this opportunity to share some of these ideas with you. I want you to be fearless in naming racism and then use that question, how is racism operating here, to identify how is racism operating in my workplace, in my child's school, in my city, and then we need to all organize and strategize to act. So thank you very much, Dr. Maxey, and I yield the floor.
Thank you, Dr. Jones. You are power. You are power.
Thank you.
I'm going to take the liberty of asking the first question. And you got me all stirred up here. There are many older people on this call who are quite comfortable in their lives as professionals and executives, and there are people who are young, who are just starting out in life. And we often hear the word that you ended with, we must work together, strategize, and plan. From a practical standpoint, doctor, and I do believe that this is the latter days of us being able to do something constructive in this country and in this world. What are several things that we can do to actualize this counter racism, the structural racism, the redlining, the death panels that are being set up? What can we really do to overcome and take our country back?
So each of us, first of all, has to recognize that we do have tools. So somebody's tools might be that they can set an agenda. Somebody's tools might be that they are the head of an organization and they're going to say, they're going to name racism. In some cities now, I'm 69 jurisdictions, one state, 25 counties, and let's say, and 43 cities have declared racism as a public health crisis. Now that's amazing. These aren't the health departments in those counties. These aren't the health departments in those cities. This is the city council. This is the board of commissioners in these counties. And so then some people say, oh, but that's all just words. I like the fact that that now nearly 70, I've lost track, maybe at least 70 jurisdictions in this country have said racism is a public health crisis. What that means is that 6 months from now, you can say, well, what are you doing about it? It's a public acknowledgement with accountability built in. But the declaration, as I say, the naming is the first step. It's necessary, but it is insufficient. So some of the people are setting up councils right now. Some of them, Asheville, I think it was Asheville, North Carolina, is already paying reparations to its Black residents. You know, there's Jackson, Mississippi is thinking about a universal basic income. Stockton, California is already doing that. So wherever you find yourself, you have power. You have power to hire somebody. You have power to mentor somebody. You have power to put something on an agenda. You have power to write an op-ed. You have power to talk to your people who look up to you or who are in your group. You know, we're parts of so many sororities and fraternities, powerful fraternities that may or may not still be talking about racism, right? So what we have is tools that we often do not recognize and use. So I would say first you need to make an inventory. What are the tools that I have? Am I teaching a course? Am I whatever? I'm going to tell you that my 3 anti-racism, 4 actually. So my 3 things is we need, for an anti-racism policy agenda, we need to be about reparations. So Randall Robinson, 20 years ago, wrote the book, The Debt. There's a new book now by Sandy Darity, William Darity and his colleague, economist out of Duke, called From Here to Equality, which is an updated look at reparations, right? So reparations to descendants of Africans enslaved in the US, that's number 1. That has to become an agenda. The second is decarceration. Our people are so imprisoned, that is sapping the strength of the whole society. Angela Davis for decades has been talking about prison abolition. I don't know how that looks, but decarceration has to be high up on our agenda. The third is massive investment in communities of color, especially, so that's investment in housing and green space and investing in our businesses and all that, investing in environmental cleanup and all, but it's also especially investing around families and around children, early childhood education, all of that, because we will know when we have won when the term disadvantaged child no longer has meaning, when we can't even imagine a child being born into disadvantage or finding themselves in disadvantage. I just want to tell you one more tool, and then I know we have to go on to the third speaker. But I'm just going to say many people in this country have never heard of the International Convention on the Elimination of All Forms of Racial Discrimination. The acronym is ICERD, ICERD. And so you might ask, what is the International Convention on the Elimination of All Forms of Racial Discrimination? Is it that meeting they had back in 2001 that the US boycotted? Is it something that happens, every other year with, people who are doing research on racism? No, it is a treaty. It is an international anti-racism treaty that was adopted by the United Nations General Assembly in 1965. The US signed it. The US signed it in 1966, but then we know that our diplomats can sign whatever treaty they want. But if the Senate doesn't ratify the treaty, it has no power on it. So I always ask people, do you think the US Senate ratified this treaty? And people are like, I don't think so. Yes, it took 28 years, but in 1994, the US ratified this international anti-racism treaty, which means that today we have international obligations to do right under the treaty. The main way that we have the obligation is we submit periodic reports every 6 years. The State Department writes these reports. I'm not making this up. This is a real thing. So the State Department submits these reports. The last report was submitted in 2013. You think there's going to be a report on this like right now in 2019? No, it was due. But anyway, so in 2013, and 82 other entities, Black Health Trust could write a parallel or shadow or, supportive report, right? The committee at the UN gets all these reports, they read it, and then they send back to each country in their turn their concluding observations. We got our concluding observations to that 2013 report in 2014. It is only 14 pages long. We can all read that today. When you get off of this, you can Google this. What did it say? It said, "Dear United States, thank you for your report. We remain concerned about racial profiling, disproportionate incarceration, the achievement gap in education, residential segregation, the health disparities and all. And not only do they remain concerned, they have specific recommendations for each of those things. We as community could use that concluding observations. And two of the specific recommendations, one was, dear United States, you need to let your people know about the existence of this treaty. So I used to do that all the time, and then I kind of let up for about a year or two, but now when I have the opportunity, I'm letting people know. And the other is, dear United States, you need to create a national action plan to combat structural racism. So that is what I think we need. We need a national action plan, a national campaign against racism.
I can now hear Paul Robeson singing, "Let My People Go." That's what we need to say. Thank you so much. Are there any questions, Michelle, in the chat box?
Okay, thank you, Dr. Jones. First off, shout out to Blue Devils. I'm the mom of a Duke alumni, so shout out that. So do have a request. Are slides available for Dr. Jones and Dr. Davis for their presentations? So we'd like to put that out there that they would love to have the slides available. And then there's a question, how do we quickly and publicly turn around the narrative that Black people have more underlying poor health conditions, and that's why more of us get sick and die from COVID, which seems to blame the victim. Most people aren't looking deeper at the reasons for the underlying systemic conditions.
That's right. So we have to challenge people when they observe something. We have to say, but why is that? We have to keep going deeper. We have to keep asking the why question. So what you say is that it doesn't just so happen. That's what you say. It doesn't just so happen that Black folks have more chronic diseases and that there is nothing genetic about race, that we have mapped the human genome. There is no basis in the human genome for racial subspeciation. It is because of racially segregated communities that you, if you're asking this question, may not have ever ventured into some of the ones that have been so segregated and disinvested. We know that all Black neighborhoods are not poor. We know that, but we are overrepresented in poverty, and our poor communities are completely disinvested and over policed and poisoned. There's a term for it, sacrifice zones. So then you have to invite people, if they really want to understand why Black people have more high blood pressure and diabetes, ask them to go across town and try to buy some fresh fruit in a store. Ask them, honestly, don't ask them to be a tourist across town. Ask them to volunteer at a senior center when it's more possible, or a child care center or something. Ask people to really burst through their bubbles and become part of the other community so they can understand this dual reality. People are very comfortable thinking that everything is open in this
Yeah.
country.
Thank you.
And
I have
I think it's,
one more question. Just put, would you
thank
comment
you for that.
briefly on the relevance, if any, of the letter years ago that was written by Willie Lynch? It seems that many of us are still in our silos and not working well together, even though we have our individual wealth. Some of us have superstar status with the NBA and billionaires, etc. How can we overcome that issue?
We need to want to. We need to feel, we need to, so even those of us who've made it buy into this myth of meritocracy. And because we're ahistorical, we think that we got where we were because we're smart and hardworking. And we are. We are smart and hardworking. But there have been smart, hardworking people in this country Black people in this country for 401 years, right? We are standing on the shoulders of others. And what we need to do is, and are being bridged by others. And we need to stand tall so other people can stand on our shoulders. And we need to stay connected and be bridges and bring people with us, to lift as you climb type of thing. But when we get all isolated and atomized, and when we believe that everything is open because we made it, and because we know we're smart and hardworking, but we don't recognize that just across town there's somebody just as smart and hardworking as we are who's dead now. What was the book, the two so-and-so? It was a book that was written by somebody who had a friend who had the same name. Both of them were Black men, and they had very different paths. I don't remember the name of that book, but let's say the two Jim Smiths or something like that. We need to recognize that we're so trying to escape something that we don't recognize that this is a struggle that is still important for the whole nation, but especially for our brothers and sisters. So if we are so disconnected that we don't even know people on the other side of the tracks, then we need to change that. Once we start changing that, then we're going to connect to their struggles and we'll join in. We will be interested in the stories of others. Then we'll start to believe the stories of others, and then we will join in the stories of others. But it takes a sense of but for the grace of God go I, we're all in this together, a sense of collective. And that is hard in this country where we're so narrowly focused on the individual.
Thank you. It reminds me, I have a friend in Cleveland by the name of Herbert Smith, and he taught me about the term called herrenvolk. And the herrenvolk, which means basically our people, our kind of people, and that is operant in certain other communities that we are not. We're going to go to a special surprise before our next speaker. I turned 78 years old in December, and my family got together along with a producer friend of mine, John Sadukas, and they gave me a birthday present. And they took me downtown to a theater, and there was a singing group called the Four Tops. That's old school. And I enjoyed the Four Tops. There was another group there called the OJs, and we were dancing in the house. And then there was another special gentleman who has consented to join us today. And my wife and I got up and we danced up and down, danced between the seats, and they called him the Woo Woo Man. His name was Jeffrey Osborne. And he is the first person I have met, Black person I've met from Rhode Island. And had lunch with him a few years ago at the National Medical Association and had a phone call with him 2 days ago. And I wanted to invite and have Jeffrey Osborne honor us with a few words, and he might do something else. Mr. Osborne, are you with us?
How are you? Can you hear
Hello,
me?
Mr. Osborne. Yes, sir.
Can you hear me?
Yes, we
We can
can.
hear you.
Okay. Well, thank you for having me. This has been very enlightening. I have to say, Dr. Kamara Jones is very, very unbelievably impressive. To follow her is, wow. In any event, I've learned a lot. I was on a call about maybe 3 weeks ago. I joined the call and I learned quite a bit from that call also. But it's an honor to be on a call with so many unbelievably uh, educated, distinguished people. And I thank you for having me on. I'm not sure exactly what you want me to do. I mean, of course, I sing better than I speak, that's for sure. But but I did grow up in the little town of Providence, Rhode Island, and there weren't many of us black people there. But you can believe one thing: there was definitely systemic racism going on there also. So I've been, I think just in all of the journeys that I've had and the millions of people that I've performed for and the stages that I've been on, I've seen so many, so many, faces of racism. And I started when I was, I guess, 1972. I joined the group LTD. But before that, I was touring also. And I mean, even in the 60s, there was still uh, colored only fountains in Georgia. So, this is it's amazing that we're still here, and it's only gotten worse, as we all know. And with this COVID-19, we're seeing that racism does play a part even in our hospitals, as people are looking at us as we don't get the treatment that we should get at times. I mean, and for the same reasons that Kamara Jones mentioned, of course, of our health system, we don't have you know the health insurance that we should have, some of us, and a lot of us are suffering from other chronic diseases that are hurting us also. I know during this whole period, I've lost 3 people that were important to me in my life. I lost my manager to COVID-19, and he was my manager for 39 years. So I realized that this is not a hoax at all. And for people to think that it's a hoax is crazy. So I've been affected by it, and I lost my drummer. He was 46 years old, and he passed away a few weeks ago. So I've been hit hard by COVID. I've had a few nieces that had it in Rhode Island, in Providence, Rhode Island, and were in the hospital for 3 weeks on respirators, and they were young enough to come through it. But yeah, but it's affected me in many ways, and it's also, affecting my whole business as an entertainer. I mean, there are no shows on my calendar right now. My last show was February 19th, and everything has been postponed or canceled, and now everything's moved into 2021, and some of the dates are now being moved to 2022. So for what I do, I've been really affected by COVID-19, because even when it does resume, they're talking about half capacity in the theaters. So, of course, that's going to affect everything. I mean, they won't be able to pay the artists as much because they won't be able to get but half the audience in these places. So it's kind of crazy how it's affected the music industry. But I've been fortunate to have a great family and a great home, and I think it's bringing me closer. It's bringing me closer to them. I've had time to now hone my craft since there's nothing else to do. I can sit around and actually study voice, which is something that you neglect after a while. You just take it for granted. And you go out and sing these shows. But now I've had time to actually put some time into it. So there are some positive things that have come out of this. Uh, but in any event, like I said, I'm not the greatest speaker in the world. But if you would like me to do a song or two, I'd be more than happy to. I'm
Absolutely.
not sure matter of fact, I'll just take requests. Are there any requests?
Michelle?
Requests for songs?
Yes.
Oh, gosh. Are
You
we
know
doing
they want
LTD? Are we doing Jeffrey Osborne solo?
Woo woo. Let's do the woo
you know
woo.
they want to hear woo woo.
Exactly. Tell Tori, you
want
want
to
to
hear
hear
Love
woo woo.
Ballad?
You know.
I think it's a woo-woo moment, Mr. Osborne.
It's a woo-woo moment.
I think it's a
Yeah.
woo-woo
Right.
moment.
Okay, we're gonna try woo-woo then. Now, Zoom sometimes is challenging because when you have more than one audio source going, it's kind of tough. So I kind of rigged up a little thing with an interface, and hopefully you'll be able to hear the music and myself sing without anything cutting out. So
Okay.
so we're gonna give it a shot. Okay, we'll try woo woo. All right, I got my son running my equipment over here.
Awesome.
Can you hear that music?
Yes, sir.
Okay, all right. We're off to a good start. Ooh, ooh, yeah. Ooh, ooh, ooh. When you want all the love you deserve, and the heat's on your mind, don't you even think about it? I'll be there just wrapped around you. I can't hold back what I feel inside. It's just a fact that you should be mine. Anything you want, you got your 45, my love. You're 45 me, you should be mine. Anything you want, you're 45 my love. Hey, you're 45 me. Can you woo? Can you woo? Can you woo? Should be mine, oh mine. Can you woo? Can you woo? Can you woo? Should be mine. In the height of your worry, where it's running too deep for you. When it all proves too much, I'll pull you through. I can't hold back what I feel inside. It's just the fact that you should be mine. Anything you want, you got your 45, my love. Your 45 me, you should be mine. Anything you want, you're 45 my love. Hey, you're 45 me. Can you woo? Can you woo? Can you woo? Should be mine, oh mine. Can you woo? Can you woo? Can you woo? Should be mine. Baby, baby, baby. Oh, girl, you should be mine. Oh, well, hey, baby, should be mine. Can you woo? Can you woo? Can you woo? Should be mine, oh mine.
Yes.
Thank you.
Outstanding.
You know,
We got a comment that you're an international treasure.
Oh, really?
I was reading something earlier today, Mr. Osborne, that it is so important, especially in times of pressure that we're under. There's so many people, there's even a new described disease called heartbreak disease. But the heartbreak is chest pain, is sweating, is nausea and vomiting, and it mimics a real heart attack. But it turns out that the people test negative for COVID. Their enzymes that would normally describe a heart attack are no longer there, but it is truly a stress generated cardiomyopathy. And one of the cures for it is to be able to take a mental break. And this is what you bring to us, in that we often say that we just got to keep our nose to the plow and do everything. But if you don't take a Sabbath, if you don't take a rest and enjoy yourself, you don't have strength. And listening to you and the fact that so many people love you and what you do is so great. If you can grace us with something short, we can go to our next speaker, okay. Renewed. And I thank you for coming on, and I hope you will join us in the future. Mr. Osborne, you're a hero.
On the Wings of Love.
I want to hear On the Wings of Love.
On the Wings of Love, yeah.
I've got Stay With Me Tonight, On the Wings of Love.
Stay with me tonight.
My brother's
Stay With Me Tonight.
If My Brother's in Trouble.
Hold on.
Oh my God, If My Brother's in Trouble, you're a real fan.
Right.
How many people know that? I'll tell you what, since I started back in 1972 with the LTD, I'm going to do an LTD song. I figure I'll go time and do a song that really started my career off.
Love Ballad.
First big hit that LTD had back in 1975. A song entitled Love Ballad.
Yes.
So, I'll sing a little Love Ballad for you.
We are at your feet.
Let's give that a try.
Yeah, you could have.
Yeah.
Your booty went back on the plane with Cherry.
I have never been so much in love before. What a difference a true love made in my life. So nice, so right. Loving you gave me something new that I never felt, never dreamed of. Something's changed. No, it's not the feeling I had before. Oh, it's much, much more. Love, I never knew that touch could mean, ooh, baby, so much. What a difference. And when we walk hand in hand, I feel so real. Lovers come and then lovers go. That's what folks would say. Don't they know they're not there when you love me? Hold me and say you care. And what we have is much more than they can see. Oh yeah. What we have is much more than they can see. What we have is much more than they can see. Yeah. What we have is much more than they can see. Yeah. All right. What we have is much more than they could see. Yeah. Ooh. All right. I saw Victoria dancing over there.
Miss Donna. Thank you.
Thank you, thank you, thank you.
Bringing
Oh,
him.
it's definitely been my pleasure. And I'm going to sit through definitely the next few speakers and enjoy this. It's really incredible and very enlightening and very educational. So thank you for having me on.
Thank you.
You're a blessing. Thank you.
Michelle, tell him who your mom is.
Brenda Lee Eggers on the call here as well, and I see she's trying to shout you out.
Oh, really? Who is that?
Brenda Lee Egger.
Oh, Brenda Lee. How you doing, Brenda Lee?
I'm great, man. I just had a rocking good time. Oh, thank you so much.
Great to see you. I love you. Love you.
I love you too, honey. I love you too.
All right.
Our next speaker is special to me. We trained at the same place in New York at Columbia University and Harlem Hospital, although I didn't know him then. He is Dr. Vladimir Bertos. When I first saw his name, I thought he was a Russian, but we quickly cleared that up. He is currently the director of the Division of Infectious Diseases and professor of medicine at Meharry School of Medicine in Nashville, Tennessee. He's a graduate of medical school in Haiti, the Faculty of Medicine and Pharmacy and Institute National. He attended Columbia, got a master's in public health. He attended UCLA for another graduate degree. He is currently full professor at Meharry. And I remember back when, for those of us who are Black, there were only two medical schools, Howard and Meharry. Now we have Howard, Meharry, Morehouse, and Drew. And we're fortunate that we have the president of Drew University on the call with us, Dr. David Carlisle. I'd like to introduce for a presentation, Dr. Vladimir Bertos. Dr. Bertos, the floor is yours.
Good afternoon, everyone. And first of all, thank you very much, Dr. Maxey, for this invitation. This is a very important program because information, communication, this is power. And I'm very grateful to be part of such a great panel. And plus to be gratified with the ballad of the great Jeffrey Osborne. So that's a lot. So I don't know if I can share my screen with you. Should I do that?
Yes.
Okay. Let me share. So as, can you see? Okay. As Dr. Maxey said, so I do practice in Nashville, Tennessee. And I'm a clinician by training, but during the past 5 years, I started to focus more on the social determinants of health because I think this is what keeps our people behind. When a patient comes into our office, we have to remember before becoming a patient of ours, this is a human being with multiple problems and priorities. A lot of time when the patient comes to our clinic, their greatest priority is not necessarily their health or their CD4 cell count or HIV viral load, because I practice mostly HIV medicine. A lot of time it's housing, okay? is they have to report to the parole officer. Where I practice in Nashville, sadly, this area has the highest rate of incarceration than anywhere in the United States. As I said, I deal with HIV patients, and the homelessness rate among our patients is 3 times higher than the homelessness rate among HIV patients nationwide. So we have big issues. So what we've done, actually recently, we started what we call practice transformation based on different tracking pathways. So we can focus on patients' priorities. For example, one of the pathways is just like patients who have a lot of social determinants of health. So we deal with them differently compared to patients who have HIV disease progression and who have developed other comorbidities. By doing so, I think we as physicians, we have a lot to learn from social scientists like Dr. Jones, who is here. Thank you, Dr. Jones, for your excellent presentation. And thank you also, Dr. Davis. So medicine is a role. It's not just with patients do not become ill. Patients become ill, not just by themselves. A lot of times it's because of the ills of society. One of the greatest illness happens to be systemic racism. And along with systemic racism, implicit bias. I know it's going to be very difficult to break down those barriers, not only to healthcare, but also barriers to wealth, to human development as well. If I have one wish, just one wish, I'm talking to politicians right now, especially today, in memory of the great John Lewis. One thing I will tell the politicians to do, strike down the part of Section 8 that prohibit convicted felons from accessing public housing. Thank you. So Dr. Davis had made a super presentation about coronavirus, the mode of transmission. So, and this is how the virus gets into the lung. So this spike protein on the left side, I don't know if you can see my pointer, S protein, which is illustrated in red here, binds to the S receptor into the lungs, where there are plenty of them. And then they go to the third one and they cause this type of pneumonia. And what you see in blue, this is the virus itself that's in the lungs. And you have a lot of reactions. 2 types of reaction, I would say. One, the body itself is trying to fight this infection, trying to fight the virus. And the second one, there is also what we call, maybe during the late stage of the disease, what we call the cytokine storm that overwhelms the human system and unfortunately cause a lot of people to be on the ventilators and cause the death of a lot of people. And those are the primary symptoms of COVID-19. Everyone is very familiar with them. But I have one caution. This is a new disease, less than 1 year old. We still have a lot to learn about the clinical presentation of this disease. I'm very glad about the presentation earlier about the conjunctivitis, because this is something we as clinicians, we do not recognize on a regular basis. So we have to be very watchful of new clinical symptoms, and also because when the disease moves from one population to another, you may see different types of clinical manifestations. So right now, the best mode of diagnosis is the PCR of nasopharyngeal swabs. You can also collect samples from other respiratory sites, but for the sensitivity for the rapid PCR for the nasopharynx is upward 90%. We do not have any proven antigen tests right now. Even for the flu, there's no real good antigen test. So it might be a little difficult to develop a good antigen test. The role of antibody for diagnosis so far is very limited because people develop antibody after they get sick. So it's not going to be very useful to make a diagnosis of acute coronavirus. It might be more useful to follow people to see if they develop immunity. That's one, but once people develop antibody, we don't know really what level of antibody is really protective, number one. And number two, if it's protective, how long is it going to last? That's a very big challenge for example, for vaccine trials. So far, the major characteristics of COVID-19, like I said, the clinical manifestations are evolving. We don't have any proven treatment right now. Most of the treatment is supportive. We don't know the real trajectory right now in the United States. So we're seeing it right now. The disease was going down and now it's up. We don't have an effective vaccine. And to me, the most shocking aspect is racial and ethnic disparities. That's why we're going to talk about. So most of the slides I'm going to be showing you, I'm going to use numbers, but don't pay too much attention to the numbers. So I use the numbers to convey the message, the same message that Dr. Jones has already conveyed to you so eloquently. And I put here a quote by Dr. Anthony Fauci, which goes like this: the impact of COVID-19 is shining a very bright light on, and this is highlighted, unacceptable health disparities. That's a key term, unacceptable. And according to him, the COVID-19 pandemic has demonstrated the weaknesses and foibles in our society. So there are a lot of data out there to illustrate the rate of racial and ethnic disparities. So I'm not going to focus on them because the numbers are changing every day. And again, this is from New York City. This slide shows you the higher rate of disease, of fetal hospitalization, and deaths among Black and brown people compared to white individuals when it comes to coronavirus 19. And again, this is the same thing like a slide that is from the CDC website. And once again, higher rate of hospitalization according by race. So Black and brown people have, once again, higher rate of hospitalizations all across the country. And once again, these slides, they illustrate the same case scenario, whether you look at it by state, and I probably would say by the county level. We probably need more granular data to look at the county level, because the data by county level, the granular data, in my opinion, it's much more informative than state data or even a citywide data. So why are we seeing those disparities? Okay. And this is a combination of cumulative factors which have created a true perfect storm within the African American and the Latinx communities. Number one, they have higher rates of preventable underlying comorbidities and higher incidence of acute medical conditions. There are also a lot of socioeconomic factors which increase the risk for exposure to COVID-19. As already said earlier, such as greater representation in essential service industries, limited access to basic primary medical care, and COVID-19 diagnostic testing due to lack of medical insurance coverage, and also lack of information, and also systemic racism, priority to whites compared to Black and brown. Lack of awareness and misinformation. Even up to today, a lot of my patients, they are asking me, is the COVID-19 real? And a lot of them refuse to get diagnosed as well. That's another issue that I have. I see too many patients who refuse to get tested for COVID-19. And again, this slide is just an illustration as what we just said. So higher risk of comorbidities in Black and browns compared to white with COVID-19. Same thing. Higher representation in the service industry. And regarding limited access to basic primary medical care, so we know that medically uninsured and underinsured due to unemployment and underemployment, as well as immigration status, do play a role in what I would call closeted cases. There are probably a lot more cases of Black and brown peoples or people, what they call undocumented individual. I wouldn't call them aliens, undocumented individuals who are afraid to go to the emergency room to call the ambulance because they feel they could get arrested. So they will die at home. They may not even know that they die of COVID-19. They may pass it unknowingly to their families. So that's why one policy change I would like to see is to encourage people who do not have a green card to come and get free testing for COVID-19. And if they are sick, they can get free care. And at the same time, most of those communities, we have a shortage of primary care physicians. Recently, there was a very good study published by Dr. Rachel Walensky from Harvard, which showed very, very great shortage of infectious disease physicians all over the country, especially where we need them. And at the same time, we have a very high concentration of those physicians around LA and around New York and in the Northeast. And so when people do not have insurance, when they are afraid, when they don't trust the healthcare system, they delay accessing medical care that they need. And then when they present to the hospital, they present with more severe disease. Lack of awareness, misinformation, and disinformation. So once again, thank you, Dr. Maxi, for doing this. This is what we need to break. At the onset of this pandemic, many in the African-American community, and maybe still today, and other underserved minority groups receive incorrect information from unreliable sources. We know the mistrust that our community have of mainstream communication channels due to the legacy of racism, stigma, discrimination, and the Tuskegee effect. we don't have any treatment for COVID-19. So the best way to access treatment, to have a chance to get good treatment, is to have access to clinical trials. Unfortunately, many of those people who are at higher risk for COVID-19 do not have access to those institutions, to those hospitals that are enrolling patients into clinical trials. So therefore, they are underrepresented in those clinical trials. So that creates a lot of problems if we ever have to come out with an effective vaccine, if we don't enroll enough Black and brown people in those trials. We won't know enough about the side effects or the efficacy of this vaccine in those communities. And lastly, what's very important, the Latinx and the African American, they are overrepresented in high-risk settings. We mentioned it already. Carceral populations, meat processing plants, as workers in long-term care and assisted living facilities, overcrowded residential areas, public transportation, for reasons Dr. Jones already mentioned. And also, especially for Latinx, farm migrants, and seasonal workers. And this is my last slide, and I will stop it right here. Thank you very much.
Thank you very much for your very astute presentation, Doctor. And while Michelle looks for questions in the chat box, I'm going to take the liberty of asking the panel first. There was an article this week in the Journal of the American Medical Association that talked about transmission of the disease by children. And they divided it into two groups. For those children from 5 to 9 years old, where the index case was 5 to 9 years old, the transmission rate was something like 5%. For those children who were aged 10 to 18, the transmission rate was in excess of 19%. So it looks like it's not the younger children, but the preteens and teens that are being infected and carrying this disease home. Would you comment on that and why this is relevant in the light of us being forced to send many of our city's school kids back to school?
I'm happy to start.
Okay.
But I don't know, Dr. Verhoeven, were you about to say something? I'm not looking at the whole. So Dr. Berthold, did you want to say something first?
Oh, that's what I'm going to say. So that raised the important question. How do we get children back to school? How and when? Right now, we don't have any answer. What I would hope, one, that we have concrete national guidance, number one. And number two, because the dynamics is different at county levels, maybe we can allow some flexibility by counties, but there should be some backbone measures that everyone, regardless of geographic location, would implement to prevent transmission in schools. So, and with some measure of flexibility. That's what I would hope. Unfortunately, we don't have this right now. So we are in limbo.
And I want to say that even the way that we're framing the conversation right now, when you listen, not the way you just framed it right now, Dr. Maxey, from the article, but many people are saying, oh, well, we don't have to worry about the children. Even when they get it, you know, it's not so bad for them. So first of all, we don't know the long-term impacts, but it's still a very narrow individual focus of what will happen to the children. The problem is not a narrow, this is not a medical care problem. This is a public health problem. We've been treating this whole pandemic as if it were a medical care problem. Even our testing is to confirm diagnosis. We haven't been doing the public health kinds of testing, but now we're seeing it again. This is a problem of disease transmission, as you say. This is a problem about children as vectors, not as children as possible patients. You know, so I think that that we'll come up with the wrong answers, the wrong strategies, the wrong timing to reopen schools, all of that, as long as we're thinking about the children as possible patients as opposed to the children as vectors in a communicable disease that is supposed to be managed with public health strategies, not medical care strategies.
One other important thing also, we don't know how long children who are infected with COVID-19 are going to be even infectious. We don't know that because we're not testing enough. We're not doing enough testing. So we need to revamp our testing capacity as well. So it's not just a one-time testing. We probably need to test people more than once, especially where there is a surge of the epidemic.
And we need to test we need to do public health surveillance testing. We need to draw probability samples of people from cell phone numbers or addresses or whatever, and then go to their houses and say, you're included in this week's sample. Test them, get the results back fast enough, and then that will give us a current, present day estimate of the prevalence of the infection in our communities. And then we can watch that over time, but it will also help us identify asymptomatic people as well as symptomatic. Then we can have them isolate. We can do the contact tracing on them. We can then have the contacts quarantine and all of that. And it won't get everybody. It's not universal testing in a whole city, but it's going to be a better way for us to say that 18% plus or minus 1% of people are infected now, and last week it was 12% plus or minus 1%. So now we have a problem. It will give us a better idea. When we're looking at the positivity rate in symptomatic people, that's a 1 to 2 week old story. That's what the story was 1 to 2 weeks ago. When we're looking at hospitalizations, that's a 2 to 3 week old story. When we're looking at deaths, that's a 3 to 4 week old story. And especially in the context of not putting the public health strategies in place, where we now have a virus that, if you take all limits off, the virus has a doubling time of about 3 to 4 days and a basic reproductive rate of maybe 3. That means in 3 or 4 days, one person became 3 people. In a week, that one person became 3, became 9. If we have a week-old picture of something that is spreading exponentially, we don't even know what it is. So it's not just, so it's the number of tests and the approach to tests. We have to have the president invoke the Defense Production Act for tests and for personal protective equipment. He did it for ventilators, but not for these other things. And that's why this country looks the way it does.
In summary, we're not prepared to open our schools. That's why I would say we are not really prepared. We are putting our children at risk if we open school in the way we would like to do. We're not prepared, really. And remember, children, they enjoy life. They want to go around and play. No, they're not going to follow all those precautions as you expect adults to do. They are children. So you have to make sure you provide a safe environment for them to grow up. That's why you have to ensure. And then the next question, how many children you're going to have in the classroom?
Okay. Well, thank you. Michelle, any questions in the chat
Wait,
box?
Dr. Davis wanted to jump in.
Yes, I'd like to make 2 points. One is Children as vectors is underrated, okay? They are important vectors. If you look at it, children are running around without masks, they're touching different objects, and they are potentially super spreaders. So we really need to get a hold on children as a potential source of causing this virus to spread so ubiquitously. And the second point is that the FDA just recently approved testing for asymptomatic individuals. There's a new test out through LabCorp. You can do group testing. You don't have to have individual testing. You can bring the whole family in, bring the whole neighborhood, up to 5 people tested in one big lot. So testing is more available. Yes, we've had the problems with systemic racism. Yes, the testing centers were out in the periphery and the suburbs, but they were also in the churches. So the churches need to step up and make it available in the community where we live and make it available to where we die in. So we need to put the pressure on the people who have the economic availability to get grants and other things to help to bring supportive services to our community. But we also need to have social responsibility to the parents to help these children to mask up and not help spread this to grandmas and aunties and other folks like that.
Thank you. Is Dr. David Carlisle still on? Is Dr. Carlisle still on?
Yes,
Yes,
I'm
he
here,
is.
Dr. Maxey.
You're the president of Drew University. I understand you had a major health screening event yesterday. I saw Dean Proto Stith on TV last night. Would you just comment on what your school is doing in that area and how you see this issue of testing?
Yes, sure. And thank you very much to the Black Health Trust for bringing this panel together. Thank you, Dr. Maxey, and thank you to the excellent panelists, including my Stanford Medical School classmate, Kamara Jones, who's always great to see and is a great leader in public health. Back on April 8th, in collaboration with the LA County Fire Department, the LA County Department of Health Services, and the Second District Office of Supervisor Mark Ridley Thomas, who really initiated the effort, CDU opened up a 7-day-a-week drive-through testing office for mobile testing site for COVID-19. We were designed to operate at 450 tests per day. We started out doing around 200 tests per day until we decided to go directly to the community, into nearby shopping centers, nearby businesses, and say COVID-19 testing is available on our campus free of charge. That more than doubled our rate of testing. And then when we made testing available to people who are walking in without a car, without an appointment, we started doing over 1,000 tests per day with an original design capacity of 450. I think the point is that in many under-resourced communities, one of the fundamental resources that's not available is a car. So if you want to reach out to people without a car, you've got to offer walk-up testing. Number two, another issue in under-resourced communities is lack of internet access. People can't make appointments if you don't have an internet connection. And so same-day appointments, walk-up appointments really worked and pushed us over 1,000 tests per day. And then finally, the other significant message that we learned in our report was about 1/3 of the people that we were doing tests on, and about 1/3 of the people who had a positive diagnosis of a COVID-19 PCR test had no primary medical home. They had nowhere to go for follow-up. They had nowhere to go for advice, nowhere to go for counseling, nowhere to go when they became symptomatic. And so relying upon an existing infrastructure in under-resourced communities underscores the need in these communities to have direct provision of services. Fortunately, through our family medicine program, we were able to provide primary medical follow-up for individuals that did not have a primary care physician or medical home. But that is an example of what is needed to make testing work in the very under-resourced communities that are disproportionately affected by COVID-19. Thank you.
Thank you, doctor. Appreciate it. When I was in residency, we had a term called LMD. That was a local medical doctor who was in the street doing all the wrong things, and we had to straighten it out at the academic hospital. As an LMD now, in my latter years, seeing a lot of patients who are exposed to COVID or think they're exposed, we do not have protective equipment. We don't have the ability to test. we don't have the ability to do anything but send them to the public health spot, and many times they send them the patients right back. For all the panelists, including Dr. Carlisle, what guidance do you give to local physicians and regular people what to do in the light that we do not have these testing facilities? And everybody cannot necessarily get to Drew, cannot necessarily get to the church on Vermont, and the few places there are. We're sort of stuck in the middle. So we give information, we have knowledge, but we can't really put our hands on helping to treat this problem. And I'm very concerned that we seem somewhat powerless. We need guidance and we need help. What can we do collectively and individually?
Dr. Carlisle?
Well, thank you. And one thing that I would say is we need to work together, even among LMDs, coalesce, consolidate, unify, organize, work with our medical societies. In Los Angeles, we have the Charles Drew Medical Society. In Long Beach, we have the Miller Lawrence Society. These are resources that can really support physicians that are on the front lines of COVID-19 out there in the community. I know when I think of my colleagues that are doing this, these are doctors who are working very hard. They're overworked, they're underpaid, and that was before COVID-19, and they're working even harder and getting paid even less now than they used to be. But they're still out there trying to do what they can to fight the epidemic. And one of the things that we've been able to do is work with them at the CDU COVID-19 testing site to make sure the patients have follow-up and are referred back to community physicians as much as possible.
There also, when some of the COVID money came to the states, it was sent directly to counties. And I'm aware that in Georgia, a lot of the counties don't really know what to do with the money. Like there were millions of dollars, 140 million for one county or something. And it's being spent kind of frivolously or even filling some of the county budget holes as opposed to going there. So the National Medical Association affiliates, as you described there, and David, the Black Docs might want to present themselves, as you said, as a resource to the counties who still might have some of this COVID-19 money and not really know what to do with it or how to get it into the communities that are most impacted. So I would say the heads of all of the National Medical Association affiliates in the cities and in the states should get together, and they should present themselves to the counties who got some direct money.
And remember, most of the federal money goes to the health department. The majority of counties do not have a health department. So we need to use a different strategies to get the resources flow to the counties.
Thank you. Michelle, how's the chat box look?
Yes, sir. We have a question prompted by Dr. Prathab's presentation, and in particular about testing. So the question, and it looks like some people have offered some responses as well. So we'll see if you have anything to add. But the question is, why are patients refusing to get tested for COVID-19? And I'll just put out a few responses to that. It says, many cannot afford to be found to be positive and be quarantined and be out of work, which is a very practical response to it.
But
that's it. And then the other is because of stigma, potential job loss. Younger people think it's a hoax or think they are immune. They don't care, have a I don't care attitude, a fatalistic attitude. And the disinformation being spread that COVID-19 testing is actually a way to be used to infect people with the virus. Those are all been offered in response to the question, why are patients refusing to get tested for COVID-19? Is anything the doctors would like to add or comment on any of those responses?
So what I would say, the main reason in my opinion is lack of information and misinformation, and also a general sense of insecurity. You know, people hear something now, and then tomorrow they hear something different. Mm-hmm. And also general skepticism toward the system. So that's the main reason for, like I said, for example, Mehari is doing testing for the city, for Schneiderville. And Mehari is running the biggest testing centers. But what we found, there are less Black people going to the centers, less Black people. And one of the reasons, like Dr. Carlyle mentioned, is probably driving. They don't have a car. And then public transportation is dismal in Nashville.
Practical barriers.
I'm glad you mentioned that. I will take your point and convey it to the leadership at Mehari to see if they can work out with the city leaders to make transportation available for people who need to get tested.
Well, thank you very much. I'm concerned that many of our people don't know some of the treatments that we do now have. We know we don't have vaccines. And even when it comes, we know that there's a big resistant community about vaccines because of historical things that have gone on in our community, whether it be Tuskegee and otherwise. And people, I think, don't have a good idea that even when we do get a vaccine is never 100% effective. It has a certain percent of effectiveness. But we do have some touted temporary treatments. Some people have raised the question of using a medication called dexamethasone. And we've been appraised that the exact virus itself may not be so much the offending agent as the virus may turn on the immune system to be hyperactive. And the so-called cytokine storm, the interleukin parts of the bloodstream, things that trigger the hypercoagulation mechanism. Would the doctors comment on some of the potential treatments we do have, not necessarily related to the vaccine itself, but what can we do to temporize and mitigate some of the things that we see going on?
I'm going to say, may I say, before you talk about specifics, the thing that we do know that works is prevention. So the public health strategies need to be number one. The social distancing, we need to call on Congress to make it as feasible as possible for more people to safely stay at home. So we need paid sick leave, we need a universal basic income, which the countries that have, like Denmark, Germany, the UK, New Zealand have implemented to pay people to stay at home. We need to certainly have a mask mandate that's nationwide. So we need to put political pressure, but even without that, we need to use the things that we do have that work. The fact that we're still not doing that fully is because we think of this as a medical care problem, not a public health problem. That is the fatal flaw in our whole response. And so what we do have are public health strategies that work. So I just want to say that, and then I'm interested in the medical care stuff too. But if you don't get it, then you won't have to worry about the treatments.
Excellent.
Yeah, so one of the drugs that was presented as a sort of a holy grail by people in higher rankings, like a hydroxychloroquine, we know it doesn't work. And it doesn't work for prevention. There are clinical trials that use hydroxychloroquine in people who are infected, but who don't have symptoms yet. So it does not prevent development of symptoms. It doesn't work at prevention. It doesn't work as treatment either. So the large clinical trial data, and unfortunately, one of the large clinical trial data of hydroxychloroquine, there was fraud also with this trial. That made it even more murky issue. So the WHO itself had stopped hydroxychloroquine trials. That's number two. And number three, trials that combine hydroxychloroquine with azithromycin show more side effects, especially cardiac side effects, rather than benefits. And other drugs like remdesivir. So the difference is in terms of days of recovery. So that's not a very significant clinical difference this trial has shown. As for dexamethasone, so this is a drug we have to use with caution because of the side effects. And we use dexamethasone only on people. So right now on people who need oxygen, whether you're on the floor or in ICU. And the other drugs that we use is a prophylactic anticoagulation. And then because of the cytokine storm that you just mentioned, Dr. Maxi. So supportive treatment, yes, this is the most common modality of treatment, really supportive treatment, oxygenations, rehydrations, and a prophylactic anticoagulation, but specific antiviral treatment, the results are not very good right now. There are still a lot of ongoing clinical trials. As of today, when I check on the clinicaltrials.gov, there are almost 1,000 registered clinical trials throughout the world. So if we have just 10 of them showing benefits, we'll be very lucky. So, but I'm very confident, I'm very optimistic that we'll find very good treatment for this virus. But for the vaccine, I will be even more cautious because this is apart from Ebola vaccine, so that will be the second time that we are experimenting a vaccine in the midst of a pandemic. And when we don't really know what are the real attributes of a true immune protection. But there is some encouraging studies with the RNA vaccine that came out of the NIH. It does show some good immune response. And that was a phase 1 trial. So it does show some good immune response. The higher the dose, the higher was the immune response. And also people who got a second dose got a higher immune response. So those data are encouraging. And this vaccine in particular is going to phase 3 trials in September, supposed to go to phase 3 trial, and they plan to enroll about 30,000 subjects into these trials. That will be conducted internationally. Another thing also, that one lesson that's very important that coronavirus has to teach us, we depend on each other, okay? As a country, we are interdependent. We depend on each other, okay? So when I buy my food at the supermarket, that depends on the migrant seasonal workers, what type of disease that person, the truck driver. So we depend on each other. And also the world is really interconnected, not only because of by trade, but also disease do travel very fast. So I hope that we'll have a global solution for this pandemic, not just a country solution. I want to have a global approach, and unfortunately, that's not happening. I would have hoped that the United States would have taken the lead for that, but we're not doing that.
Well, thank you. I talked to 2 gentlemen this week. One is Dr. Cameron Webb, who is an internist in Virginia, who also happens to be a candidate for the U.S. Congress. And he will become the first Black male physician in the U.S. Congress. And he's going to be one of our speakers. He speaks on public health and COVID as well. And I spoke with Dr. David Satcher, who at one time was the director of the CDC and Surgeon General of the United States. And we expect those 2 to be featured next week. We've had a number of world-class African-American physicians on, and we certainly have had them today. I'm challenged by all of you and hope you will come again. I'm going to ask, are any of our National Medical Association colleagues on for comment? Is Dr. Rich Williams, Dr. Norris, Dr. Towler, any of the others on for brief questions or statements? Michelle, do you see any of those doctors on?
Dr. Norris.
Is Dr. Norris on?
He
Yes.
was. I'm not seeing currently.
Okay, are there any questions in the chat room?
There was. Any experience with donated plasma from recovered COVID-19 patients? Any COVID-19 donated plasma available?
I know that convalescent plasma has been tried to treat patients. It's more successful when those donors have very high expression of antibody levels. The higher the expression of antibody levels, the greater chance is a success. But it's a very difficult procedure. So it's not for every institution. So it's very complicated to do. And we don't have any monoclonal antibody right now. We don't have any hyperimmune globulin. So right now, but we do have a lot of ongoing clinical trials. And as I said earlier, I'm very optimistic that we'll find a treatment. I'm very optimistic we'll find an effective vaccine. I'm not sure when. I'm not sure if we're going to find an effective vaccine by the end of this year, but in the long term, given the great collaboration, once in a lifetime collaboration that's happened between industry, government, and academic centers, this gives us great hope for the common good.
Okay, I have another question of concern for all of our doctors on the call. Right now, there are many patients who have discomfort, some illnesses. Many of them have pre-existing conditions, which would put them at greater risk for COVID, but they stay away from urgent care. They stay away from emergency rooms and hospitals and doctor's offices. But in light of their increased vulnerability and the need to make sure that they don't get treated too late, what is our guidance for our patients in our community for seeking care in general and care specifically for what might be a pink eye, what might be a cough, what might be an elevated temperature? What is the best advice of them seeking care in this time of hazard?
So the patient, they have very good reasons to be scared of COVID-19. That's number one. And number two, at the same time, I would be very concerned myself if patients abstain from seeking care they need for, let's say, for a heart attack or a stroke. So they should talk to their primary care physicians to seek for advice regarding their primary care, regarding urgent care. That would be my recommendations if you have a primary care physician. So now for those, like many of Black and brown people who don't have a primary care physician, now, Dr. Maxey, you hit me hard. So I don't have an answer right now, frankly. Not only many of them don't have a primary care physician, so many of them that don't have they don't even have a working telephone. So that's a more difficult question for me to answer.
I'm wondering if the hospitals could at least make a push to communicate that they have a dual entry, like so for people who have COVID symptoms and for people who are pretty sure they don't. Just that communication would let people know that they could get to an emergency department if they were feeling some crushing substernal chest pain and not worry about getting COVID.
That certainly will allay the fear, but at the same time, that may backfire and can create discrimination between COVID and non-COVID.
There are certain code words that patients utter when they go to the emergency room, and they'll get you automatically sent to the tent. So we have to solve that problem. You know, I feel somewhat guilty, Dr. Jones. I know today is special for you, and you gave up your time. I know everybody else did too, but this is a special day for you. It's your second anniversary, and I'm being a little bit humorous. So I'd like you to give us a last word, and I promise to send some flowers in the name of your husband, Dr. Jones.
Thank you. I just want to appreciate what you're doing here with the Black Health Trust. I just want to reiterate, even though we are physicians here, the observation that I've made that our nation's narrow focus on the individual is being reflected here, and that we're treating this public health crisis as if it were a medical care crisis. And what if some of the resources that were being invested in clinical trials were instead invested in PPE or in tests or in making the schools safer or something like that. And so what we're doing is we're waiting until people get sick and then we're responding to that. When in fact, there are ways to prevent people from getting sick. And we act as if what we're seeing is inevitable, and it's not. It's because of poor decision making and poor deployment of resources. And New Zealand has 0 cases. Okay, they had some come in, but they immediately clamped down. I know they're an island. I know we're much bigger, but we're bigger means we also have bigger resources, and we could be doing better. And the things that we know to do right now are public health things. So even as physicians, we need to, as Dr. Davis did early on, and as Dr. Maxey did early on, when as soon as you guys started talking, we were talking about we have to do the, hand washing, mask wearing, don't touch your face, social distancing, all of that. And we need to communicate these same things to our policymakers who are still also viewing this as if it were a medical care problem. It is not. It's a huge public health problem, and because of our approach, it's become a huge medical care problem, but it did not have to be that way. So that's it. And I know you guys are going to keep on talking, but thank you for understanding that today is my anniversary. My husband's been he's always very patient with me, but I need to honor him now. So I'm going to take my leave. Thank you all very much.
Enjoy. Thank you, Dr. Jones.
Happy anniversary.
Okay, thank you. Bye-bye.
Okay.
Dr. Maxey?
Yes.
Hi, it's Dr. Tyler.
Hello, Dr. Tyler.
Hi, I just would like to make a couple of comments parroting off of what Dr. Jones said about prevention. And I think although we're focused on the COVID virus, because that is the disease of the day, the most significant disease of the day, what has been commented upon about pre-existing conditions, comorbid conditions, we cannot forget about these things. And because you're speaking to a wide audience, I think this is also the opportunity to instruct or educate people about things that they can do to improve their overall health. And of course, that starts with what you're eating. And this has been brought up before, but I think we need to get into more particulars, perhaps on a future call, about people taking a serious look at their diets and seeing what are the things that are predisposing them to pre-diabetes, to high cholesterols. And there are some very specific guidelines that can be used to try to improve our overall health.
Why don't you briefly list a few of those, Doctor?
Okay, well, for example, if you take the general rule of staying away from anything white, okay, white flour, white sugar, white pasta, flour in general, because flour basically turns into sugar. So, a lot of times people think I'm not eating a lot of sugar, I'm not eating desserts, but if you're eating a lot of flour in your diet, breads, pasta, noodles, all those kinds of things, white potatoes, those basically will turn into sugar. When the glucose store is used up and it gets into storage, it can create more fat in the body. And that, of course, predisposes to prediabetes and diabetes.
So we're basically told to eat the colors, right?
Eat the colors, as multicolored as you can. This is where color is good and color is important. You also want to stay away from the sodas.
Give an example of those foods with color, please.
Oh, well, the more colorful, the better. Carrots, you want red peppers, you want green peppers, lots of greens, mustard greens, collard greens, all the green family, broccoli, Brussels sprouts. Those are the cruciferous vegetables, and those help reduce the incidence of cancer. You want to eat monounsaturated fats. There are good fats and there are bad fats. And the good fats are like avocado, almonds, walnuts. Those are the healthy fats. Olive oil. Very importantly, you want to stay away, if you learn nothing else, stay away from the highly refined seed oils. Sunflower oil, canola oil, grapeseed oil. A lot of people think grapeseed oil is good to cook with because it has a high boiling point. But no, it's highly refined, which means it's created a lot of chemicals that are actually going to impact your body's health. So the best oils to cook with are avocado oil, ghee, and coconut oil. And olive oil, if you're going to heat it at a low heat, you don't want to cook on high heat with olive oil because it has a low saturation point.
So we're going to have you on in a week or so, Dr. Tyler. You've got a trove of knowledge that we want to give our audience the chance to hear. We're going next to closeout time. I want to see if there are any last comments or questions, and then we want to be off of here in the next few minutes. But thank you so much, Dr. Tyler.
And high fructose corn syrup, stay away from it.
Okay. Michelle, any other questions in the chat box we need to deal with right now?
Awesome. Thank you so much to all of our presenters today. There are no more questions. However, I would like to give a shout out to Martin Pratt, who is one of our producers of the program. And he's also on the steering committee for the Black Health Trust. So Martin is having a birthday tomorrow. So I just want to give him a happy birthday. And Mr. Osborne, you blessed him today because you're one of his favorite artists. So that worked out really well. Happy birthday, Martin.
Congratulations.
Happy birthday, Martin.
Martin, you're getting
Thank you.
Congratulations.
Thank you.
Okay. I'd like to welcome everybody to distribute this call. We're going to be on every Sunday. We're looking at maybe making it an hour later so we can pick up the Los Angeles people who go to church and still work with the people on the East Coast. We'll be making that decision this week. We want you all to invite as many people as we can. Our mission is to give credible healthcare information to all the people of color that we can, Latino, Black, and everybody. It's important that we empower ourselves, and knowledge is power. I'd like to thank all of our speakers, Dr. Davis, Dr. Jones, Dr. Bertos, and I'm going to say Dr. Osborne, because he definitely treated us. We thank you so much. And if there's no other point of information to be given, I'm going to ask Ms. Brenda Lieger to end this quickly in our usual way.
I thought we decided not. Oh.
Is Ms. Ager on?
Brenda, you want to give us a quick affirmation?
I most certainly will. Well, knowing that there is one life and that life is God, it is everywhere present. It is our lives right now because in God, in this power, we live and have our beings. So we know that the outcome will come. And so I'm blessing everyone today, and we'll see you again next week in love and laughter and music and health and wholeness. So it is.
Thank you, everybody. Have a good day.
Stay
Thank
safe,
you.
everybody.
Thank
Bye,
you.
Steph.
Be safe.
Bye,
Thank
Jeffrey.
you. Bye, Brenda.
Hey, Joy. Hey, Tori. I mean,
Hey.
Bye, Martin.
Bye, Martin.
Martin
Bye,
still on?
Yep, I'm still on.
Hey,
Have a great birthday.
Have fun.
And look who that is up there.
Hey, Kimmy. Okay, I'm signing off. We're still being recorded.
Okay. Bye.
Bye, guys.
Did we cut off the streaming?
Nope, I'm trying to get Simon to make me host and couldn't, so we just ended it.
Okay.
Simon, end it, please.
You have reached the voicemail box of
Judy, is Simon still on the computer? We need to end the call.
Oh, I think you stepped away. Okay, I'll tell.
Yeah, because it was still streaming.
Okay.
All right.
Well, streaming, that's on Facebook. Because I saw it said live, which is not, well, that's Facebook. Yeah, he said he picked up. It's in the
It's but we don't want to stream that on Facebook either.
Yeah, I don't know if he did.
Martin, he said he didn't have access to Facebook. Okay, how you doing?
I'm saying just end it. I'm telling him to just end it.
Okay, tell
I
him to
texted him. I just called him.
whatever he can end, tell him to end it.
Thank you.
Okay. Okay, all right, thanks. He said he ended it, Martin.
Me and you wouldn't be able to talk if you did. So I don't know. I'm gonna try to sign in and see what I can. Simon killing me.
I'm calling again.
Hello?
Yeah, me and Martin are still on Zoom.
What?
If he ended it, we wouldn't be able to
Well,
talk.
let me go back in there. They're still on there.
I'm just gonna have him from now on at 5 o'clock make me a host, and I'll end it the way it's supposed to be ended.
Okay. All right.